All right, folks, thanks for tuning in. This is going to be a presentation on mild traumatic brain injury for the DeSales University Physician Assistant Program. So mild traumatic brain injury is extremely common, and you will definitely come in contact with this at some point during your clinical practice. Whether you're in the emergency room, urgent care setting, family practice, you're going to be involved in this process. So it is typically benign. However, if it's not addressed or if you miss something, there can be some serious consequences as a result. This is actually an important public health concern, particularly in the Commonwealth of Pennsylvania, because recently there was a law passed regarding minor head injuries in sports players and their need for medical evaluation before they're allowed to return to sports, particularly high school sports. So at some point, this is going to be a common thing that you're going to see in your clinical practice. So important considerations here in the management of a mild traumatic brain injury include identification of any immediate neurologic emergencies, such as a brain bleed, recognition and management of any neurologic defects that happen as a result of the injury, and then prevention of any cumulative or chronic brain injuries. Mild traumatic brain injury occurs with head injury due to contact and or acceleration or deceleration forces. And what does that mean? Acceleration force would be you're getting hit from behind, and that's forcing your head to move forward and strike something. So for instance, if you're sitting in a car and your car gets hit from behind, that's going to force yourself forward. A rapid deceleration injury would be if you're in the car and you'd strike something at the front end of the car and your head would come and hit and rapidly stop against the steering wheel or the windshield. It's typically defined as mild by a Glasgow Coma scale of 13 to 15, measured approximately 30 minutes after the injury. So you all know that a Glasgow Coma scale of 15 is considered to be normal. It means that you're alert, you're oriented, you're following commands, you're speaking appropriately. Patient with GCS of 13 might be altered and may not follow commands initially. The term concussion is often used in the medical literature, and it's sort of synonymous with a mild traumatic brain injury, but it does describe sort of a subset of milder brain injuries. The International Multidisciplinary Conference on Concussion in 2012 stated that a concussion is a brain injury and is defined as a complex pathophysiologic process affecting the brain. This is induced by some type of traumatic biomechanical force. There are several components that incorporate the clinical, pathological, and biochemical injuries, all right, that we can see here in a concussion process. All right, so a concussion may be the cause of a direct blow to the head, face, neck, or somewhere else in the body with an impulsive force transmitted to the head, aka you were hit with a baseball bat, you got hit in the head with a ball, you fell down some steps and you bumped your head on the way down, somebody smacked you upside your head real hard. All right, so that's be like the inciting incident, this impulsive force that's being transmitted to your head. Concussion typically results in a rapid onset of short-lived impairment of neurologic function. Okay, and it typically resolves spontaneously. However, in some cases, signs or symptoms can evolve over minutes to hours. Concussion may be a result of a neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than a structural injury. Let me say that again. We're talking about a functional disturbance rather than structural damage. Okay? And as such, no abnormality is seen on standard structural neuroimaging studies. So, the patient comes in with got hit in the head, maybe had a little bit of a loss of consciousness, is now confused, maybe a little nauseous. You CAT scan their head, and the CAT scan is completely normal. because there's been no structural injury. No structural injury to the head. Okay, this is a functional disturbance. So a concussion results in a graded set of clinical syndromes that may or may not involve a loss of consciousness. That's important to know. So they may or may not have a loss of consciousness. They don't have to have a loss of consciousness. Resolution of the clinical and cognitive symptoms typically follows a sequential course. However, it's important to note that in some cases, symptoms may be prolonged, because as we've been discussing, every patient's different, every scenario is different, so not everybody's going to be able to fit into this niche, if you will, of, well, if you have this, then it's got to be this, and you have to resolve in this amount of time. Everybody is different. All right, so here's some background, some statistical data. Approximately 1.74 million people sustain a traumatic brain injury in the United States every year. About 75 to 95% of these things are considered to be mild. What do these come from? They come from motor vehicle accidents. People fall down. They get hurt at work. They're out doing recreational accidents like ATVs, skiing, and such. And then 5 to 17%, sadly enough, are from assaults. In the elderly population, falls are certainly more likely to be the cause. Motor vehicle accidents are more common in younger folks, but you can still see them in geriatric population. But in the geriatric population, as you've been learning, because these folks end up having some type of gait abnormality or some other issues, they are definitely more prone to falls, and as such, mild traumatic brain injuries. Now that's in the normal geriatric population. Take a geriatric patient who's on Coumadin and have them fall and hit their head. Now we're not necessarily looking at mild traumatic brain injury. We could be looking at a pretty significant bleed in their head. So just keep that in mind. Some more background information. Sports injuries typically are involved with mild traumatic brain injuries, particularly contact sports like football, hockey, rugby. The annual incidence of sports-related concussions in the U.S. is 1.6 to 3.8 million, which is a significant number. And the likelihood of an athlete in a contact sport experiencing a concussion is as high as 20% per season. In fact, in football alone, an estimated 10% of U.S. college and U.S. colleges and 20% of U.S. high school players sustain brain injuries each season. That's a significant number, folks. This is why Pennsylvania law changed in the last couple of years to make sure that these folks are not just getting put on the sideline, let them walk it off a little bit, and then they can return to play. If you get a head injury, you must be evaluated by a licensed practitioner and be signed off and be cleared to play before you can go back. That is now a law in Pennsylvania. All right, so mild traumatic brain injury is common among soldiers who participate in combat. The Army here did some surveys of over 2,500 soldiers. They were performed at 3 and 4 months after they returned from a 1-year deployment in Iraq. 5% reported injuries with a loss of consciousness, and 10% reported injuries with altered level of consciousness. The mechanism of injury varied. They could be from blasts or explosions, falls, motor vehicle accidents, shrapnel, or bullet wounds. All right, so here's the pathophysiology. A mild head injury may result in cortical contusions, aka bruises, due to coup and contra-coup injuries, and I'll show you a picture of that in just a second. While the axonal rupture from shear or tensile forces can occur at the time of severe head injury, milder degrees of axonal damage are postulated to play a role in mild traumatic brain injury. What the heck does that mean? It means that if you have a significant blow to the head or significant shear forces, that alone can cause axonal damage. Okay? But what they're saying here is that mild injuries can just may play a little bit of a role in mild axonal damage. Okay? Disruption of the axonal neurofilament organization impairs axonal transport, leading to axonal swelling, degeneration, and transection. Release of excitatory neurotransmitters such as acetylcholine, glutamate, aspirate, and the generation of free radicals may contribute to secondary injury. So this all goes back basically, folks, to an inflammatory process. you may get a little bit of axonal cortical bruising. And as a result of that bruising, you will get an inflammatory response here. So you'll get some swelling. You may even get some nerve damage, all right? But for the most part here, this is going to be related to swelling, release of excitatory neurotransmitters, and some free radicals being released in the area there. Here's a picture of what this coup and contra-coup injury looks like. So if you look here, here is the baseball bat hitting the head, all right? And you're getting the damage done to this area here. The brain is moving forward in that direction there. The contra-coup injury is when the brain smashes here and then smashes back in that direction there. So it's like it gets rattled. So initially the brain moves forward here where the impact is, and then it will fall back and hit the back part of the head. And you end up getting brain injury here and brain injury here. So this is known as the coup, and the secondary impact is the contra-coup injury. So this is where you can say, well, geez, they got hit in the head, but they may have visual disturbances or some other problems here. Well, that's because the injuries are both sustained to the frontal area here and to the posterior area. Clinical features. The hallmark symptoms of a concussion are confusion and amnesia. And this can be with or without a loss of consciousness. Okay, and this can appear immediately after the head injury, or it can take several minutes later. But remember, you don't have to have a loss of consciousness to diagnose a concussion. In fact, this can be a real problem sometimes because the people who don't have a loss of consciousness, sometimes the diagnosis of concussion is often overlooked, particularly in some sports injuries here, because they didn't have an LOC. People think, oh, well, then they just got his bell rung a little bit, he's okay. When in reality, they actually sustained a concussion. Amnesia with a concussion is pretty common. It involves a loss of memory, typically of the traumatic event, but it can either include a loss of recall prior to the event, which is known as retrograde amnesia, or the events that happen immediately after the trauma, such as anterograde amnesia. And you can do this by simply asking, the patient, what was the last thing that you remember? Well, I remember catching the ball, and the next thing I remember is being in the ambulance. Well, maybe they had a little bit of a combination of retrograde, they don't remember the impact, and the anterograde, meaning they don't remember getting put on a backboard and, people evaluating them on the field. It just depends on the patient, all right? It also may be apparent, that the patient has amnesia with regards to like short-term memory because they'll ask repetitive questions. So they'll ask you what happened, and you can explain it to them, and then about a minute or two later they'll ask you again what happened. That would be indicative of somebody who has a concussion. Now keep an eye on these types of amnesic properties here, because we'll use that then as a baseline and try to figure out if they're improving or deteriorating from there. So these are potentially important things to kind of grasp in your history, because it kind of gives us an idea of potentially how severe the injury is and if you're improving or not. Early symptoms of concussion would be things like headache, dizziness, nausea, vomiting, you're not aware of your surroundings. These are going to be common complaints that patients are going to have when they first come to see it in the emergency room. Later symptoms that can develop hours or days later might be mood or cognitive disturbances, sensitivity to light and noise, and sleep disturbances. These you might see in the emergency room as well, but most of the time someone's going to get hit in the head, they're going to have a headache, maybe a loss of consciousness, some nausea, vomiting, and that's going to prompt them to come to the emergency room for evaluation. All right, now observed signs of a concussion. These are things that you and I can appreciate by just inspecting the patient and talking to the patient. So a vacant stare. They may just be staring off into space and not necessarily focused on you. They may be very slow to answer questions. They may have an inability to focus their attention. You may be talking to them, asking questions, and they're looking off, and it almost seems like they're not paying attention to you. Oftentimes they are disoriented. They're not aware of where they're at right now, what day it is, or what's going on. And they sometimes can have some slurred or incoherent speech. In addition, they may have some gross observable incoordination. They may be stumbling, they won't be able to walk a straight line. You would notice this on like cerebellar testing of a neuro exam. They may be emotionally unstable. They may appear upset. That's not an uncommon thing to happen. Memory deficit, very common. They ask repeated questions, and if you were performing like a mini mental status examination and asked them to remember 3 objects, they would have difficulty in recalling these objects. And then any period of loss of consciousness that would be observed by any bystanders around, that would be conducive here of a concussion. Seizures. You can see a seizure in somebody with a mild traumatic brain injury, although this generally occurs in about less than 5% of the population. Now, this is not considered to be epilepsy, and you can see these seizures within minutes or several days after they've had the injury. 50% will occur within the first 24 hours of the injury. Now, those who have a seizure earlier in the onset of the injury, they're more likely to show a generalized seizure, meaning like a tonic-clonic activity. And those folks who have a seizure early on in the injury increase the risk of developing epilepsy in the future. So someone gets hit in the head and within 15 minutes has a seizure, they are more likely to have a generalized seizure, and they are more likely to develop epilepsy in the future as opposed to someone who developed a seizure 7 or 8 hours after the injury. Now, complications can develop from a concussion. Typically in a mild traumatic brain injury, when you do a CAT scan or an MRI of them, you are not going to find structural damage. However, depending on the degree of the bruising that takes place, you can have some swelling, which can give you some complications, or some of these patients may develop an intracranial hemorrhage, at which point they would technically go from a mild to a more severe traumatic brain injury. This is why serial neurologic exams and someone keeping an eye on the patient after they go home is going to be so important. Now, in a lot of patients with a traumatic brain injury, they may sustain a blow to the head, and they may be dizzy for a few minutes, but it resolves and they get better from there. Some of these patients, though, develop significant bruising with these brain contusions, and depending on the size of the contusion, they may be accompanied with some localized ischemia and edema, and then from that edema, they can actually get a mass effect, which once again will increase your intracranial pressure. This results from the direct external contact force going against the intracranial surface, or the brain slapping, against the intracranial surface from the traumatic forces. Signs of contusions vary based on their number, size, and location within the brain. They can include focal neuroscience. They can include confusion and impaired consciousness. And because you have these brain contusions, it actually may delay the recovery from the concussion itself. So you have a patient that presents to your emergency room with a headache and a little bit of nausea, vomiting, and some dizziness after they got hit in the head at football practice today. And you decide to evaluate them in the emergency room by observing them for maybe about 4 or 6 hours. And while they're in the emergency room, they start to have more focal neurodeficits, or they start to have an increased, they have a decreased level of consciousness. Well, if you have patients that have rapidly deteriorating neurologic signs, you have to consider the notion that this patient's now evolving to an intracranial hematoma, that they've got some type of a bleed in there that's been slow, that's starting to be apparent now. And this could be a subdural, typically not epidural, that would be a little bit more acute findings, or an intracerebral bleed. So signs of a worsening headache, focal neuroscience and confusion and lethargy, all this may progress to a decreased level of consciousness, and if you don't address it, it could even result in death. All right, so intracranial bleeding here. You can have a subdural hemorrhage, and this occurs when trauma results in tearing of the bridging veins or the dura. And this can be acute, subacute, or chronic. So this doesn't have to necessarily present today to be a subdural hemorrhage. You could have a patient that presents 5 days after the injury and now has evidence of intracranial bleeding. This is why it's so important for you to get a decent history on these patients and ask the question, was there any recent head trauma? Were there any recent sporting events or car accidents that may have triggered a slow bleed that leads them to this point now? Now, in contrast to that, epidural or intracerebral hemorrhage is usually arterial, and it's usually pretty acute. And this can be showed up within minutes or hours from the original injury. Now, about 20 to 50% of people with these epidural bleeds, they have what's called a lucid interval. So typically what happens here is they may get hit in the head, they may have a loss of consciousness, they can wake up and maybe be a little disoriented, maybe a little nausea, vomiting, and they feel like they're going to be okay, and then all of a sudden they rapidly deteriorate on you neurologically. That should make you think epidural/arterial bleeding. Here's a diagram that kind of it shows you how this all looks here. So here in the epidural, let me get my pointer here. In the epidural bleeding, you can see it is on the outside here, in the epidural space here. So you have a little bit of a fracture there, and this is arterial bleeding in this area here. And it puts pressure against the brain in here, and it gives you that mass effect. You can see it on the CAT scan down here. This is epidural, and you can see this where this line would be here. Now it's starting to bow a little bit over, so this is a little bit of midline shifting here. So this is in the epidural space. The subdural space is below the dura. It will still push against the brain and give you this mass effect, but you can see how different it looks here, having being underneath the dura here. Okay, so here's a teachable moment for you. This is Dr. Hellwig's approach to head bleeds. This is an easy way for you folks to remember the difference between the two. And it's all about remembering vowels and consonants. So with an epidural bleed, E being the vowel, you should remember that it is arterial, oval on imaging, and interval, meaning that they have that lucid period that we were just talking about before. Versus a subarachnoid bleed, which is a consonant, the S. It's typically venous, and it has that lacunar shape on imaging. So this is a quick, easy way to help you remember the difference in the presentation of a subdural bleed versus an epidural bleed. Okay, so other associated injuries that you can be found as a complicated concussion would be like skull fracture, facial fractures, spinal cord injuries, or spinal bone injuries. That's something you need to consider. If you get struck in the head, that force to the head can also cause damage to the neck, and it can also cause damage to the major blood vessels in the neck. So just because your patient comes in complaining of headache and a blow to the head, you should always consider evaluating the neck. Skull fracture may be accompanied by pathologic findings such as a brain contusion or dural tears or vascular trauma, aka bleeds. All right, so how do we evaluate these patients when they present to us with these injuries? Well, any patient that's suspected of having a concussion or a mild traumatic brain injury needs to be medically evaluated. And like I stated to you earlier, it is a Pennsylvania law now that kids that are involved in school activities that sustain a head injury must be evaluated by a licensed medical professional before they can be returned back to playing status. All right. Now, when you're evaluating these folks, what do they need? Well, they need obviously a neurologic assessment, and they need some type of mental status testing. Patients with, prolonged unconsciousness, persistent mental alterations or abnormalities on their neurologic exam, they require urgent neuroimaging and even possible neurosurgical consultation. Why? Because if they're persistently unconscious or they persistently have neural findings, you need to scan that head and make sure there's not a bleed going on there. That's the big factor here. So if there's something going on here, you need to be aggressive and address it quickly or get them to the appropriate specialist before they decompensate on you. Now, cognitive assessment, this should be done by a trained medical provider. Lots of people don't necessarily recognize the concussion or that there's a cognitive impairment because they're not trained to observe that. And so a lot of these things get overlooked, which is one of the reasons why Pennsylvania made that law that these folks get evaluated by a professional. Simple questions of orientation are not as adequate. So this is why they've developed a number of diagnostic tools to help us diagnose the concussion and kind of decide where they fit into the scheme, if it's serious or not serious, and how, the level of cognitive impairment that is present. So here are some standardized cognitive assessment tools that are used. So there's the standardized assessment of concussion, and this is basically just a sideline evaluation of athletes. It just gives you some basic information here. It's useful, but it's only useful if you have some baseline data. And unfortunately, that's the fault of many of these cognitive assessment tools. If you don't know what the baseline status is mentally of these students before you do the examination, then it is tough for you to compare it. So you always need some data on what these people were like prior to, and a score in order for some of these tests to be validated. There's the post-concussion symptom scale and graded symptom checklist. This rates the severity on from 0 to 6 for 15 to 30 different symptoms. But it's not a valid test without any baseline data. And that's difficult because unless you're like a team trainer and you're going to go out and you're going to do cognitive evaluations at the players, on all the players at the beginning of the season, and then keep that stuff recorded somewhere, then these tools really aren't helpful to you. There's the Sports Concussion Assessment Tool number 2, or known as the SCAT-2, and this is becoming more commonly used. It's scored on a scale from 0 to 100. Normal numbers, though, have not necessarily been defined or validated, but this tool is starting to be used a little bit more often. The Westmead Post-Traumatic Amnesia Scale is typically what's used in emergency rooms. It's fast. It takes less than a minute. Incorrect response to any question is considered positive for cognitive impairment. Here are the questions. What is your name? What's the name of the place that you're at? Why are you here? What month are we in? What year are we in? What town or suburb are you in? What's your age? Your date of birth. What time of day is it? And then you can give them some pictures and ask them to recall that. If they don't get one of these right, that counts as a point against them. So it's a pretty fast, easy tool to kind of give us a decent cognitive evaluation. Neuroimaging. I know we've been talking about any patient that comes in with significant neurosymptoms, they're going to get imaged. But a lot of these patients you can evaluate clinically and say, do they need a head CT or not? The patient that comes in that fell and bumped their head, but comes in, did not have a loss of consciousness, is alert and oriented, no focal neurodeficits, is tolerating PO, they're not nausea, vomiting, they have a normal gait, they're acting appropriately. They may not necessarily be worth a scan at this point, particularly if they're, in their 20s and 30s. A guy who comes in who's 85 years old and bumped his head and, maybe on Coumadin or something, then you got to image them to make sure there's not a slow bleed there. Now, for people with mild traumatic brain injuries and concussions, typically we don't find any abnormalities at all on a CT scan. Only in about 5% of patients will we find anything wrong. CT is your test of choice because ideally we're trying to see, is there a bleed or any evidence of mass-occupying lesion or something that's going to cause herniation? CAT scan is a quick, easy way to determine that. MRI is typically used for the evaluation of persistent post-traumatic symptoms. So your patients with post-concussive syndromes, a neurologist is probably going to want an MRI to get more fine-tuned, detailed images to see what's going on in the brain. So who do we image? Well, there's different criteria out there that can help you decide who needs a CAT scan and who doesn't need a CAT scan. Particularly, there's the Canadian CT head rule and the New Orleans criteria. Both are validated and both follow an algorithm format to decide should a patient get a CAT scan or not get a CAT scan. So here's just one of these algorithms here, all right? So here's what you're looking for. Any patient with a Glasgow Coma scale less than 15, any suspicion of a depressed skull fracture, any signs of a basilar skull fracture, 2 or more episodes of vomiting, age 65 years or older, amnesia before the impact of 30 minutes or more, dangerous mechanisms such as a pedestrian struck by a car, you were ejected from the vehicle, patients who are coagulopathic, anyone who had a seizure following the incident, focal neuroscience, or intoxication. Now, why intoxication? Well, these folks, they're impaired, so they're not going to be good historians. Also, because if they have slurred speech and a funny gait, you don't know if that's related to the alcohol or the fact that they got a bleed in their head. So if any of these things are present, then you're going to consider imaging them. If it's an abnormal CT, they're going to get admitted and you're going to get a neurosurgery consult. If the CT is normal, then you're going to go back and say, okay, well, a Glasgow Coma scale less than 15, are they coagulopathic, any seizure, or they don't have a responsible caregiver at home? If that's yes, then they're going to stay in the hospital to be evaluated because you want to make sure that they don't deteriorate overnight, and so someone needs to keep an eye on them. If all those things are absent, you can do outpatient observation. If they're going to be at home with a responsible adult, somebody that can check on them and realize that if for some reason they're not acting appropriate or they're starting to develop focal neuroscience, that they would get them right back to the emergency room. That's appropriate. Now, if all these things are negative here, then you don't need to image them, and they can go home with some type of outpatient observation. So it's a pretty handy tool. Now, what about kids? This is my daughter, Kayla, and I'm so glad she looks like her mother and not like me because she'd have facial hair and be going bald. But, what about kids? Do we image all these kids? I don't know. If that kid came in to the emergency room right now, looking like that, following a head injury, would you image him? Most of you would probably say not. So, this is my son, Bradley. Definitely would not image a kid that looks like that coming in the hospital. Well, what about big kids? Well, big kids don't count. We've got that criteria already addressed with you. All right, so do with kids here. Well, here's a skill that you can use, a validated tool to assess the severity of traumatic brain injury in kids, and this will give you an idea of who needs to be imaged or not. So first thing you're going to look at is age. Are they less than 2 years, or are they between 2 and 18 years of age? And then we say, okay, they're less than 2, but they've got a normal mental status. They're acting appropriately to mom and dad. They didn't have a loss of consciousness. The mechanism of injury is not considered to be severe based on this information that you got down here. There's no frontal scalp hematoma, and there's no evidence of skull fracture. Well, then those kids are probably going to be okay with just observation and good follow-up with their pediatrician. Same deal here. If they're over the age of 2 and they've got normal mental status, no loss of consciousness, no severe mechanism of injury, they're tolerating PO, they're not vomiting, they don't have severe headache, and they don't have evidence of basilar skull fracture, then those folks too also will probably not need any type of neuroimaging. And then you don't need to subject these little kids to high doses of radiation. Now on this slide here, okay, CT of the head is required if any of the following criteria are present. So witness loss of consciousness greater than 5 minutes, amnesia here greater than 5 minutes, abnormal drowsiness, they vomit 3 times after the head injury, suspicion of a non-accidental injury, aka was this abuse, seizure after the head injury in a patient who has no history of epilepsy. Those folks are going to get imaging. On your exam, if they have a GCS less than 15, they're going to get imaged. You have a suspicion of penetrating or a depressed skull fracture. If they have evidence of a basilar skull fracture, focal neurodeficits, presence of bruising or swelling or laceration greater than 5 centimeters. All right, if someone's less than a year old, those folks are getting imaged as well. High-speed road traffic accident, like if they were a pedestrian or they were on a bike and they got hit. A fall greater than 3 meters in height, which would be, about 15 feet. And high-speed injury, it wouldn't be 15 feet, sorry, that would be like 9 feet, about 10 feet in height. High-speed injury from a projectile or an object. Someone hit a baseball and they got hit in the head and it was a pretty significant velocity. Those folks there, they need to be imaged. If none of the above variables are present, then the patient has a low risk of intracranial pathology and you probably don't need to image them. So you have mom and dad in the emergency room with their kid who got hit in the head. Maybe they fell out of bed. They were jumping on the bed, they fell, they bumped their head on the dresser on the way down. Very common scenario. The child is tolerating PO liquids and solids. They're playful. They're running around the emergency room, and they're responding well to their parents. These folks can just be observed. They can be observed. The true typical observation period is about 24 hours. 6 hours of that after the incident is going to be in the emergency room. So generally, you keep these kids in the emergency room, you have the nurses check on them, you go in and do serial examinations on them, and if they're fine after 6 hours and they're tolerating PO and they're running around playing, they can go home. Mom and Dad's going to keep an eye on them in the next 24 hours. You're going to give them pretty strict guidelines on what to look for so that they recognize if there's a problem, they can come back. And the kid can sleep tonight. We don't wake kids up every couple of hours anymore. All right? So Mom and Dad's going to ask that question. Should I wake them up every hour? The answer is no. Kids can go home and they can sleep. As long as they've not developed any focal neurodeficits or any deterioration in that 6 hours, they're okay to go home. And they can sleep. All right, adults. People that we're going to consider for observation, if they have negative neuroimaging, normal exam without significant comorbidities, then they can be observed for about 24 hours, and this can be done generally at home, as long as they're with a responsible adult who, once again, can recognize signs of deterioration and bring them back to the hospital. Now, patients who need to stay are people who are at immediate risk for a complication, such as those who persistently have a Glasgow Coma scale less than 15. Those who have an abnormal CT scan, such as intracranial bleeding or cerebral edema. Folks who've had seizures or any type of abnormal bleeding parameters from underlying coagulopathic processes, like they were on Coumadin or whatever. They need to stay and be observed to make sure they don't develop signs of deterioration. So if you're going to send a patient home for outpatient observation, you need to review some of the warning signs on when family members should bring them back. And that's an inability to awaken the patient, severe worsening headaches, somnolence or confusion, restlessness, unsteadiness, or any type of seizure activity, changes in vision, vomiting, fever, or stiff neck, urinary or bowel incontinence, weakness or numbness involving any part of the body. These are generally printed on your discharge instructions from the hospital, but these are things you should be aware of and should just review with the family, make sure they understand these things, that if the patient develops any of these symptoms, they need to come back for further evaluation in the emergency room. Now, long-term effects of mild head injuries, for the prognosis for them is generally pretty good for a complete recovery, as long as the concussion has been recognized and managed appropriately. There are some short and long-term issues, though, that can develop. These would include what's called second impact syndrome, post-concussive syndrome, post-traumatic headaches, post-traumatic epilepsy, post-traumatic vertigo, and chronic traumatic encephalopathy. Second impact syndrome occurs when there's a second concussion sustained while you're still recovering from the previous concussion. And this results in diffuse cerebral swelling, all right, and you get this cerebrovascular congestion and malignant cerebral edema, and that causes increased ICP. It is rare, and some people believe it's a controversial complication, but a 2013 systemic review showed that there's really no risk factors with any certainty could be found that would necessarily say you're going to develop this syndrome. So it's a controversial topic, but it is still out there in the literature, and I wanted to make sure you folks were aware of it. Post-traumatic headaches can occur in 25 to 78% of patients following a mild traumatic brain injury. The onset of a post-traumatic headache should typically be within 7 days after the injury. Headaches may represent a specific injury to the head or neck, but may be nonspecific in character and may have symptom patterns that are indistinguishable from other headache syndromes, such as migraine and tension headache. So once again, patient presents to the emergency room with migraine-type symptoms, who's never had a migraine before. A good history is going to be real important here because a head injury might be in that history. Post-traumatic epilepsy. Mild traumatic brain injury is associated with a twofold increase in the risk of epilepsy for the first 5 years after the injury. Now, seizures occurring within the first week of an injury are considered to be acute symptomatic events and are not considered epilepsy. 50% of the seizures consistent with post-traumatic epilepsy will occur within the first year. 80% will occur within the first 2 years. Now, some people want to know, can you prophylactically treat these folks with anticonvulsants, and does that prevent it? It does not, and it is not recommended. The incidence of post-traumatic vertigo has not been well characterized in prospective studies. It's typically related to head injuries to specific areas or due to specific mechanisms, such as direct injury to the cochlear or vestibular structures, the labyrinthine concussion. You can also have trauma, which causes rupture of the oval or round window and presents with a sudden unilateral like sensory hearing loss and acute, persistent, and gradually diminishing vertigo and ataxia. Chronic traumatic encephalopathy, there is evidence out there that repeated concussions can cause a cumulative neuropsychological deficit. In addition to the cognitive impairment, this neuropsychological symptoms such as behavior and personality changes, depression, you can have Parkinsonism and speech and gait abnormalities also. It's interesting because they're finding increasing reports of dementia among American National Football League players with a history of multiple concussions, and this is also seen in patients who have been boxing. There's a lot of documented cases on that. Post-concussive syndrome or post-concussion syndrome is common following mild traumatic brain injury. It's a symptom complex that typically includes headaches, dizziness, neuropsychiatric symptoms, and cognitive impairment. A loss of consciousness does not have to take place in order for you to develop this PCS. This is a controversial topic because many of the symptoms of this are self-reported and they're subjective, and you can't really prove that the patient is experiencing dizziness. You can't really prove that they're talking about like persistent nausea and those types of things. So it becomes difficult sometimes to make this diagnosis and find true data that supports it. 30 to 80% of patients with a mild to moderate brain injury will experience some symptoms of post-concussive syndrome. Now you need two of the clinical criteria to basically make this diagnosis based on the International Classification of Diseases, ICD-10 and the DSM-4, or which now would be DSM-5. These things are commonly used, but they give different results. So if you read one resource, it says this is the actual criteria needed to make the diagnosis, and another source tells you that it's something different. So that becomes controversial. The severity of the injury does not clearly correlate with the risk of post-concussive syndrome. So in other words, whether you got hit in the head with a pencil versus a baseball bat, it does not change the risk of you developing post-concussive syndrome. Now the pathophysiology is based on theories. There's the neurobiologic factors theory here, which shows that a number of structural and biochemical changes have been documented in animal models of head injury and in human neuropathological studies. These patients had like a measurable global atrophy when you compared it to a control group 1 year after the injury. There's psychogenic factors. The symptom complex of PCS, such as headache, dizziness, sleep impairment, is similar to the somatization seen in psychiatric disorders like depression and anxiety. So anxiety and depression can produce subjective and objective cognitive deficits that are similar to those seen in PCS. And these things have been shown to improve with antidepressant therapy. But once again, is the anxiety and the depression related to a post-concussive syndrome, or does the patient have underlying issues that predisposes them to anxiety and depression? All right, so the clinical features of post-concussive syndrome. Most patients will complain typically of headaches. That's pretty common. Some will complain of persistent dizziness, and then others complain of fatigue, irritability, anxiety. Insomnia is pretty common. Loss of consciousness is pretty common. Loss of memory, and noise sensitivity. So headaches. They are estimated to occur in about 25 to 78% of people following a mild traumatic brain injury. We talked about that earlier. We also said that it should occur within 7 days after the injury in order to call this a post-concussive syndrome type headache. Most of these post-traumatic headaches can be classified as either migraine or tension headache. About 50% of patients report dizziness after a mild head injury. Some of these are pretty nonspecific, such as lightheadedness, but others have true vertigo, and this could be due to benign paroxysmal positional vertigo or because they had a concussion to the labyrinth area of the head. Interestingly enough, a number of studies suggest that complaints of dizziness at the time of injury and afterward identify patients at risk for a prolonged recovery. So patients who present with dizziness, either right at the time of injury or shortly thereafter, they have a higher risk of a prolonged recovery from their head injury. So psychological and cognitive symptoms. Over 50% of patients report a personality change, irritability, anxiety, depression after a head injury. They find themselves intolerant of noise, they're intolerant of emotional excitement and crowds, and they are more susceptible to the effects of alcohol. They report impaired memory and concentration ability. They complain of fatigue and a disruption of their sleep patterns. 15 to 20% of these people will develop symptoms meeting some criteria for a psychiatric disease. Diagnostic testing needs to be individualized to each patient depending on their complaints. Folks who are complaining of persistent vertigo symptoms should be referred to an ear, nose, and throat specialist. Folks that are complaining of visual symptoms should go see an ophthalmologist. And then folks who are having issues with depression and anxiety and post-traumatic stress, they really should be evaluated by a psychiatrist. Neuropsychological testing is not typically helpful with post-concussive syndromes. However, the evaluation can be helpful for folks that are having prominent cognitive and psychological complaints. And maybe that evaluation shows that they're just mild deficits, and so you can go back and provide reassurance to these patients based on this cognitive or psychological evaluation to say they're not as bad as you think they are, they're actually quite mild, and they may actually get better from there. In addition, this testing may actually help you find an underlying diagnosis, such as the patient already had depression prior to the injury, but now the results of the injury have just made the depression more apparent. And so this can help you maybe pursue an alternative diagnosis rather than labeling them as a post-concussive syndrome. Neuroimaging as a part of the diagnostic workup for post-concussive syndrome may not be needed because most patients have had some type of neuroimaging during their evaluation of their traumatic brain injury. As stated earlier, anywhere from about 5 to 10% of CT scans can be abnormal in a patient with a mild traumatic brain injury, and they might show subarachnoid hemorrhage or subdural hemorrhage. Patients who have not had imaging, specifically an MRI, who have disabling complaints, they should be imaged. This will help to exclude more serious pathology that would either identify a worse prognosis or an alternative cause for their symptoms. The treatment for patients complaining of post-concussive syndrome typically is reassurance. Most patients just need simple reassurance that these symptoms typically resolve and show improvement within about 3 months. There's actually some data out there that shows that bed rest for 6 days following the injury reduces the symptoms of post-concussive syndrome. For patients with post-concussive headaches, amitriptyline has been widely used for post-traumatic tension-type headaches as well as nonspecific symptoms such as irritability, dizziness, depression, fatigue, and insomnia. Remember that amitriptyline is a tricyclic antidepressant, so not only does it help with these pain syndromes and controlling chronic headaches, but it does have its antidepressant effects as well. Propranolol is typically used sometimes as a controller medicine for things like migraine headaches, and you can use this with or without amitriptyline to aid in prevention of these headaches. NSAIDs for the treatment of headaches has shown great improvement as well. So the treatment of folks with psychologic or cognitive complaints following a head injury, current evidence does not provide information for the treatment of these complaints that are specific to the post-traumatic setting. Donepezil, aka Aricept, has had some positive results in preliminary studies in patients with really more severe traumatic brain injuries, but it has not been studied in folks with post-concussive syndrome. The use of cognitive retraining and like neuro rehab for folks with cognitive deficits is kind of controversial right now, whether there's a true benefit there or not. And folks who are complaining of anxiety and depression, psychiatric medication may be helpful in managing their complaints. Education will be extremely beneficial for both the patient and the family following a head injury, especially in these patients who are developing these post-concussive syndromes. Patients need to be reassured that their symptoms are not out of the ordinary, that many people experience these symptoms following a head injury, that it's a diagnosed syndrome, and so they need to feel that reassurance there that they're not an outcast, that they are a part of a very common subset of people who experience these symptoms following a head injury. Prognosis with regards to post-concussive syndrome, the symptoms and disability attributed to the PCS are greatest within the first 7 to 10 days for the majority of the patients. At 1 month, symptoms are improved in most of the cases. In fact, many of them have resolved at this point, but the vast majority of patients have largely recovered by about 3 months. So for providing reassurance to your patients, the worst of it's typically over 7 to 10 days. Significant improvement is noted at 1 month, and the most patients, the vast majority, have recovered by 3 months. A minority, about 10 to 15%, still have symptoms that persist for 1 year longer, but that, like I said, is only about 10 to 15%. Folks who have pending litigation or are currently in litigation or getting some type of compensation, aka workers' comp or disability benefits, they have a strong, consistent risk factor for persistent symptoms and disability after mild traumatic brain injury. In fact, some patients with persistent disability may be malingering, aka faking, so that they can maintain their benefits. So keep that in mind in patients who have this persistent, ongoing symptoms following a mild traumatic brain injury. Not that I'm saying you should get tunnel vision and assume the worst. You should always assume the best in your patient. But at some point, if they're not getting any better, you say, geez, are they really falling into this 10 to 15% that have this prolonged symptoms? Maybe this should be something to consider in your differential. Folks with repeated concussions may lead to more severe and more protracted cognitive deficits, and I gave you numerous studies that prove that. Also, the female gender is an inconsistent risk factor for persistent symptoms. Folks, thank you so much for tuning in and viewing this presentation. I hope it was helpful for you. As always, I am available via email should you have any questions or issues, or certainly come see me in my office. Please feel free to go back and review the slides again, write down your questions, and come see me with any issues that you're having. Thank you so much.